Well, it's time. I'm going to just get started. Welcome, everybody. I know almost everybody here. I think we've all met, actually, except for Ken, through the course of the day. My name's Michelle Lindsey, and I am a longtime TapRooT instructor, and I also currently am working at South Lake Regional Health Center as the interim quality and risk manager. So I'm going to talk a little bit about things that we do at South Lake, but also trends in the industry and outside of healthcare as well for caring for staff after an incident. And I have to thank Benna and Ken for the topic, because after Mike Williams' talk last year, and I left very really heartbroken for Mike Williams. He was from the Deepwater Horizon. He was one of the, if you saw the movie, the real Mike Williams was here. It wasn't Marky Mark. But he talked about some of what happened to him after the incident. And it really was a lack of care after an incident. And this is something that, as an organization and a culture, that we've worked really hard to move forward in our journey. So I'll just tell you a little bit about the hospital that I work in. We're a 408-bed hospital in North Greater Toronto area. We have about 113,000 emerge visits per year. We have about 3,500 staff, almost 600 physicians. We have 70 patient and family advisors that work actively with our committees and programs. We have a huge number of volunteers that help our hospital operate. Our hospital was really designed for about 70,000 emergency room visits. We function at about 124% capacity on average through the year, peaks at flu season, so it's been extremely stressful. And one of our biggest challenges currently, and with the Canadian healthcare system, and it may be a little different in yours, but because of our overcapacity, we struggle because we have something called alternate level of care patients that take up beds in our hospital. We can't send patients home if they don't have a place to go that's suitable, that meets their needs. And so we have roughly, at this point, about 68 patients that are ALC patients that are taking up beds that cause a backlog in our emerge department, where people may sit for days trying to get a bed. So we've been working with the province, the Ministry of Health and Long-Term Care, to find solutions. We've reopened a hospital that was mothballed to provide that alternate level of care outside of the hospital. And we're now starting the first of its kind program in the province called South Lake at Home, where we will coordinate the care and the additional services so that our patients, when they're coming through the doors and admitted, we're starting to work on that plan for discharge so they can be safely discharged home and free up beds. So it is a struggle. It puts a strain on our resources and our patient experience, that's for sure. We just unveiled a brand new strategic plan. And so a couple of things I'll just highlight. I'll talk about this again. This was a very collaborative process with all of our key stakeholders, not just within the hospital and our patient and family advisors, but with our community and service providers. And so our newest tagline is leading edge care by your side. Our values have been reworked, but they're always with compassion, the power of many, serve with purpose, every voice matters, and the courage to think differently. And these were reflections of our staff and our patient needs. And then we have 4 strategic goals. So the one I'm going to talk a little bit more about is around an environment where the best experiences happen. We have an incident management system that we created. We have been fine-tuning, honing, and creating some policies, practices, and guides, and toolkit for our staff. And so what this has helped us do is it helps us provide better oversight for all different types of incidents, regardless of their severity. And so we have filters that incidents pass through that may dictate not just the most severe incidents, we don't call them sentinel events, we call them critical incidents, but not just the most severe incidents get a deep dive and a root cause analysis. But if they meet several of these considerations, then we may take those through and give them opportunities to learn. And depending on the type of incident, then we have different levels of accountability in the organization for the outcome and different committees that provide oversight for those incidents. So whether it may be down here where we provide trend reports quarterly, all the way up to the board or to directors, we're constantly monitoring our incident reporting system. So through this, we've been able to leverage one of our really powerful committees, a quality of care committee, that provides oversight for those critical incidents. And we've extended it beyond that so that we can take incidents that have the potential, a greater likelihood of creating harm in the future. And so that oversight committee provides us an opportunity to then do a very thorough and comprehensive investigation in collaboration with the programs that are involved, in collaboration with our patient and family advisors. We have patients participating in our incident reviews. Not the whole thing, but they participate in fact gathering as well as recommendation review. It provides a quality check in terms of the process. It reviews recommendations. This is our quality of care committee or oversight committee. And it looks for transferability across our program. So if it's a surgical incident, we may still have transferability over to our cancer center. And then we provide the ability to monitor to ensure those recommendations get put in place and are working. So because of that, it's been really helpful for us to leverage our learning from things that were near misses, critical incidents or severe harm near misses, that we may not have got the attention where somebody walks out of the hospital. There were the good old days when it was like, we're glad that that's over and keep moving. So we have an opportunity for a deeper dive.